The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're fortunate to be able to spend another week talking to our good friend Pete Lindgren, who is going to talk to us today about, I think, some very interesting things that he's able to follow in his role supervising newborn care in the Canyons region of Intermountain Healthcare. I've entitled today's episode, Interventions and Consequences, a work in progress. It occurs to me that I think that's a Lost Paul Simon album, but I can't remember for sure. So if you find that, it may be a bootleg, feel free to share it. Welcome back, Pete.
Thanks for having me back, Paul.
Have you developed any more meaningful disclosures than the ones you've made in the last 2 weeks?
I have nothing to disclose.
Okay. All right. So over the past few years that we've been talking to people on this podcast, we've talked about two big changes in recommendations, and we've actually talked about two versions of both of these things. We want to talk about a little bit about bilirubin recommendations and about early onset sepsis surveillance, especially related to Group B strep. And we don't want to spend as much time talking about those particular changes, although we'll summarize them briefly. The main thing we want to be able to talk about is one of the things you have access to is a lot of information, a lot of data that tell us about what these interventions have done. So let's talk. One of the things that I have really admired in watching you guys at work doing this is that people like yourself and Kanye Ling, who has been on the podcast before, is look at the data in an ongoing fashion and make adjustments that enable us to treat infants more rationally. Would you disagree?
I would agree. I think, Paul, one of the things that I would also point out, we have really wonderful data analysts that we work with. And it is one of the strengths of being in a system like this. And when we look at the data, we'll oftentimes come up with questions and think, oh, I wonder if we could look at this. And I have to tell you that almost all the time, Eric Henry has already thought about those questions and figured out ways of putting them into the data. And so it's really a pleasure to get to work with folks like Kanye and Eric and Dina Olson, because they really are good at figuring out how to both kind of ask the questions and then search and query the data and develop ways of looking at that kind of help us understand, what we're doing and look at the impact of it, both in terms of clinical outcomes, but also in terms of what we're doing in terms of cost.
Trying to walk the fine line between doing too much and too little. That we definitely want to keep babies safe, but we want to do that in a way that's sustainable and that does the right thing. Let's start with the issues related to bilirubin. So there were recommendations, I forget what year they came out, and the new recommendations 2022. In a nutshell, what are the big differences between the older recommendations and the newer ones?
I would say the biggest recommendation is being able to stratify risk in a different way, but then the treatment thresholds for phototherapy are higher. So effectively, fewer babies end up being treated with phototherapy.
One of the things we should point out, when we talked to Bob Christensen about bilirubin several years ago, he pointed out that the original Butani curve is based on very few infants. And one of the changes has been is that there have been so many more babies followed over the years.
Yeah, huge numbers of babies followed. I love Bob's way of doing this, saying, how did we arrive at this? Was the statistical method of the BOGSAT method, which is the bunch of old guys or girls sat around a table method. So it was all kind of expert opinion, and to some extent still is, but with a lot more data.
Let's be honest, that's where most things have to start anyway. The good news is it has the strength of much more science now.
Definitely a lot more. And, and the old guidelines have been in place for about 18 years. So we were operating on the 2004 guidelines. So it was time to graduate.
Okay, so as we've graduated, and clearly one of the challenges, given that I work in one of your hospitals much of the time, one of the disadvantages is that the previous advantage is that the approach was all built into the medical record. So it's very easy to say, so here's the number, here's the bilirubin level, here's what you got to do. And now you have to go outside the system to figure out what to do.
That has and continues to be frustrating. As you probably know, in 2024, we are still within the iCentra system, within the Canyons region of Intermountain Health.
That's a Cerner product.
We'll move to Epic soon.
Yeah.
And much of the energy in terms of doing any of the work within the electronic health record system has been shifted towards the changeover to Epic.
If you were giving advice to someone about, so I want to follow the latest guidelines, what's the simplest way to do that, both within your hospital or wherever someone may be?
Well, there are a number of different apps to use. I believe that if you're within the Cerner system, it's actually using the updated treatment threshold guidelines. The University of Utah developed an incredibly useful and rich app that does the same. I think what's happened in our system is that people are linking to and putting data in BillyTool, so billytool.org, which has worked really well. And one of the things that I'm really happy about is that we knew that phototherapy rates would decrease if people were following the updated 2022 guidelines. And that's exactly what we've seen. So our phototherapy treatment rates were kind of ranging from anywhere from about 6 to 9% over the system. And we are down to about 2 to 3% of babies in the hospital who are receiving phototherapy, which is a huge decrease. And the kind of back of the cuff calculations for last year suggested that was about a $2.1 million savings in healthcare costs. So even without having a decision support tool within our electronic health record, people have adopted the new guidelines and are using them. And we've seen a decrease in the rate of phototherapy use.
And at the same time, you're tracking that decreased phototherapy use. I'm sure you're also tracking both babies who have developed very high bilirubin levels as well as kernicterus.
Right. So the aim of treating babies with phototherapy is to prevent kernicterus. Interestingly, Paul, I think from 2009 to 2018, there were 7 cases of kernicterus in the state of Utah. Since 2018, there's not been a single one. We are also tracking bilirubins over the level of 25. We've had none in the last year to date, and I think maybe only one last year. So we are not seeing an increase in severe hyperbilirubinemia, despite the fact that we are using higher treatment thresholds. So we continue to catch the babies that have risk through the universal screening, and those babies are presumably being treated appropriately.
So it sounds like a win-win.
I think it has been a win-win. And again, I think it's amazing that that has happened, even though we don't have a decision support tool that's baked into our electronic health record. So newborn providers are having to put that data in. But I think that speaks to kind of the character of pediatricians. They figure out what the right thing to do is, and they're willing to kind of do the extra work to do the right thing for their patients.
And if anything, that would also suggest that there may be some room for improvement in facilitating access to the guidelines that could even tighten things up even more.
Yes. And I think because we don't have those thresholds built in, it is difficult to tell if people are actually adhering to those guidelines. So it may be that people are initiating phototherapy below the therapy thresholds. We don't know because we don't have that built into the system yet.
And the other things that we've saved in the process, it would sound like, would be decreased testing and also decreased exposure to phototherapy, which is not just a cost issue, but has not a lot, but some potential for side effects as well.
Yeah, and I think one of the things that maybe isn't considered as much, phototherapy is not a fun thing for babies or families in general. They don't like to be on it. I certainly think that it interferes with bonding and breastfeeding. It would be interesting to know whether the decreased rate of outpatient phototherapy has led to better breastfeeding outcomes and fewer readmissions for, poor weight gain and such.
Yeah. There's clearly more questions to answer, but again, this is the thing that struck me about this, thinking about this as a topic, is that careful application of a guideline, then careful application of a refinement of that guideline has been quite successful in your experience.
It really has. And I think while it's hard to kind of implement new things, when you can see the value in it and you can actually track the progress of that, that's really satisfying. And, I think we all get a piece of that, right?
Yep.
And that we can actually contribute to doing things in a way that, actually do have better outcomes and you can show it.
Yeah. Well, let's talk about the other experiment that I wanted to ask you about. And that's, going back to 1996, the CDC said that we're missing too much group B strep, that we were seeing too much group B strep disease. And so we've seen now a series of recommendations that came from there. For one thing, that universal group B strep surveillance. And then, there were guidelines that then had recommendations based on whether someone had received antibiotics, and that there were a lot of people who got a lot of testing based on that. In addition of whether a woman had been diagnosed with chorioamnionitis in the delivery process and what the surveillance process was then. And then we had this bold leap that instead of being a flow chart, we went to mathematical risk stratification, which sort of, entered the data into a black box and then gave us a recommendation. Tell us about your experience both with the original experiment and then the refinements that you've seen over the last couple of years.
Well, as you said, Paul, we, from really kind of like through the 70s, 80s, and 90s, there was that process of looking at how do you decrease the risk and rate of GBS sepsis in babies. And so on the obstetric side, you went from screening based on risk factors to universal screening. That has meant that we've been able to identify, which mothers have risk. We knew that, if a mother had a fever or had signs of an intrauterine infection or chorioamnionitis, that the babies had a higher risk. You knew that if they were, early, they had higher risk. But we went from treating all babies whose mothers had chorioamnionitis with antibiotics, right?
Mm-hmm.
To kind of saying like, well, does that even make sense? Because chorioamnionitis is something that is a difficult diagnosis to achieve. It's a pathologic diagnosis based on examination of the placenta. So you really don't know that for certain until after the baby's been born. So we would get these presumptive diagnoses, and much of it was subjective. So the task really was, how do you develop a system where you're making decisions based on actual data and trying to like use that for risk stratification, and particularly things that were like readily available. That was sort of what happened. So trying to remember now, I think the most recent GBS prevention and treatment guidelines came out, I think, in 2019. So we were using the old guidelines. And then in 2021, we went from using that multivariate analysis to using the kind of modified multivariate analysis. So we were treating babies who had a EOS risk based on that Kaiser calculator of like greater than 1.5 at birth. And all those babies would get a blood culture and antibiotics, and we would do a CBC and CRP on those babies. Turns out, of course, that CBCs are not very useful for risk stratification for GBS.
Which is a huge thing, right? That runs counter to, people of a certain generation were trained that that's the gold standard.
Yeah. And, this is, again, one of those amazing things that people a lot smarter than us have kind of looked at from a statistical basis to figure out, which things actually matter for doing risk stratification for early onset sepsis.
The other thing is that also in that pathway that you were talking about, there has also been a period where if someone tested positive for group B strep and had not had antibiotics long enough before delivery, that was also a group of babies who got automatically surveillance and treatment. And so a lot of babies were getting a lot of IV antibiotics for a while.
Yeah. So I think when we've looked at this, the antibiotic prescribing rates, I think, were kind of almost up to 10% of babies. So really a considerable number. And so one of the aims in using this multivariate analysis is to try to decrease the number of babies that are actually getting antibiotics.
So the first thing I think was being tracked was, are we decreasing the amount of group B strep sepsis? And the good news is the answer is yes, right? That all that intervention decreased group B strep sepsis.
Right. So I may not have the numbers right on the top of my head right now, but I think the rates were something like 7 or 8 babies per 1,000 in the 1970s. And currently, I think our rate within the Intermountain system in the last few years, I think, is 0.22 per 1,000.
The number I have from the CDC is in 1993, when they started to intervene, we were at 1.7 cases per 1,000, and that the CDC's number right now is 0.2 cases as well per 1,000, that's huge. That's an eightfold change.
Yeah. And as you and I both know, GBS sepsis can be really, really bad.
Yeah. And so then the next step is, if you put this black box calculator in place, is that sufficient? And your data would suggest it has been?
Amazingly, we have not missed a single case of a positive blood culture for early onset sepsis. We have, since June of 2021, I think there have been about 76,000 babies born within the system. And I think there have been 17 babies with positive blood cultures that were considered to be actual pathogens. So yeah, I mean, that is the 0.2 per 1,000. And so we have not missed anyone. And of course, you and I both know that we're going to treat many babies with antibiotics, but we are treating fewer babies than we previously did with the previous strategy.
And that too leads to a difference in cost. And I think arguably a difference in perception of babies by parents, which also I think has effects on the way they see their baby, which probably has bonding effects, as well as actual probably breastfeeding effects, because maintaining an IV and all that sort of stuff requires some distance.
Yeah, certainly. And depending on, which hospital you're in, if you're on IV antibiotics, you may very well have been separated from your mother, at least at some point, for administration of antibiotics. The other thing that's interesting is that once antibiotics got started, people didn't really have a great idea of when to stop them, right?
Sure. Mm-hmm.
So there is this idea of like, well, you were really sick when you were born and your CRP was high, so we're going to give you 5 days of antibiotics or 7 days of antibiotics, despite the fact that your culture is negative. So the other thing was that the blood cultures, when you have a blood culture, you get a milliblood, the sensitivity of that test is really quite good. So when you have a negative culture, it is reasonable to stop, unless, of course, you have some other clinical reason that you would continue, like the baby has, evidence of a pneumonia. So the rate of babies getting antibiotics more than 72 hours has also decreased, which is another one of those things that the duration of antibiotic therapy has decreased, but then those babies are no longer in the hospital. And going back to the kind of thing of how does that affect bonding and breastfeeding and, just kind of like how people see their babies, that's a big deal. So if we have these kind of uncertainties, like, well, your baby the CRP is still a little elevated. They might still be sick. Like, those are hard things, I think, for people to kind of understand. And I think even for physicians, we would oftentimes treat until there was normalized CRP. So I do think that there's considerable improvement. Just of note, we were doing about 6% of all babies in the system prior to this had a CRP drawn. Currently, it's 0.4%. So another one of those areas where we are doing fewer labs, which I think is a really huge improvement.
Fewer labs, and you would argue with no loss in important clinical information.
Yeah. And again, the CBC numbers, we're as high as 14.5% of all babies were getting a CBC this year to date. It's 3.4%.
And that's fewer, the way I do the math.
By about 11%.
Yeah. So not everyone who practices newborn medicine has access to the sort of resources that you do. So speaking to somebody who's perhaps in a smaller system, community hospital, what recommendations would you take away from your application of these things that would be helpful to someone?
Well, I think that one of the really amazing things is that the AAP has a lot of really great guidelines, right? So we have the guidelines for perinatal care. It's probably not something that everybody's reading all the time, but there are national standards for many of these things. And I think being familiar with those is really important. Before that calculator was put into iCentra to do the kind of risk-based calculation, the Kaiser EOS calculator, it's line, right? That's something that, someone could use. And I think people actually do use.
I do actually use it.
Yeah.
Yeah, I see babies in a community hospital and I look up an adjusted EOS score for all the babies I see.
I think understanding kind of how babies then are stratified in terms of risk based on their clinical picture is also probably a good idea. So the objective measures that are used to look at that would be simple things like heart rate, respiratory rate, temperature, and whether or not babies are actually on oxygen.
Those are important things, right? Of course, the important thing to take away from all of this is that clinical care of a newborn is the number one thing, and being able to evaluate babies and manage them intelligently is always going to be important. It does strike me, though, that one of the things that comes out of this is as things change, it behooves all of us to look at that, because this does challenge some of our cherished preconceptions, about how useful is a CBC right after a baby is born. How useful is a blood culture right after a baby is born? Because I think there was a time where we thought, well, they're not very sensitive, but it turns out they can be extraordinarily sensitive.
Yeah, and I think, Paul, the other point that is often made is that even though there are guidelines that help with risk stratification, they should still be used with clinical judgment, right? These are guidelines, and you don't want people to stop thinking. I think there is the tendency sometimes for us to just fall back on what does the guidelines say I should do?
Right. That's not going to be sufficient, especially if you followed the guidelines. Doesn't mean that there's not another process going on. We really appreciate your time and your expertise. Thanks for taking time to talk to us the last couple of weeks. For those of you who have questions, please send your questions to questions@vcurb.com and we'll deal with those next week. Thank you for liking and subscribing, because that's the only way people can find this podcast. Thanks to Elisa Stoddard for making it sound like a podcast. And thanks to Janice for listening. So thanks, Pete. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.